Hello everyone, welcome to another episode of Next Saviours Essential Question Series NEET PG 2025. Today we are going to have a discussion on the differential diagnosis of thrombocytopenia, which are very frequently kept in your examinations. As a NEET PG aspirant, we are very much confident that we can solve the question related to thrombocytopenia based on the question that we solved during our practices. But when we sit in the examination hall, it becomes extremely difficult to identify that what is the correct answer for that particular question. So until and unless you don't know that what are those specific markers which could be provided into or which could be hidden in the long questions, it is difficult to reach the final answer. So let's decipher it. Let's try to find it out how to reach the correct answer related to the differentials of the thrombocytopenia. Now, before we talk about the question related to this topic, let's see. There are multiple causes of thrombocytopenia. Like there could be decreased platelet production, as you know, that bone marrow failure, bone marrow infiltration, nutritional deficiencies, some of the drugs like uh, methotrexate, cyclophosphamide, and infections, congenital disorders like Fanconi anemia, Viscodt-Eldridge syndrome. So all of them are the causes for the decreased platelet production. Another category is that of the increased platelet destruction. The causes could be divided into immune-mediated or non-immune-mediated destructions like ITP, the drug-induced, the heparin, the systemic lupus erythematosus, antiphospholipid syndromes, and the non-immune like TTP, HUS, DIC, HELP syndrome. So all of them are the causes. Another series of the cause is that of the sequestration, where there is hypersplenism, Gaucher disease, congestive splenomegaly, and there could be a dilutional thrombocytopenia because of the large volume infusions. But majority of your questions are asked from the increased platelet destruction, right? So these are the common differential diagnoses which are kept in the questions in particular. And as we have already talked about, that increased platelet destruction could be immune mediated or non-immune mediated. And among the non-immune mediated are the TTP, the HUS, the DIC, and HELP syndromes. So let's see what are the common options which are provided to you. The common options obviously are related to the increased platelet destruction like DIC, TTP, HUS, ITP, and on the basis of which the question is framed, although we are going to have a discussion on this question later. But you can see that the first thing that they are going to provide is the clinical features. The second thing that they will be providing you are the laboratory markers. And on the basis of this, then they will ask you what is the most likely diagnosis for this particular question. So let's see what are the particular differentials which are kept and how to differentiate each one of them from the other. As you already are aware of that, what is the role of ADAMTS13 enzyme in thrombotic thrombocytopenic purpura. Now, all of you are aware of this that ADAMTS13 is a disintegrin and metalloproteinase with thrombospondin type 1 motif member 13, which is a zinc containing metalloprotease enzyme, and it is responsible for cleavage of the ultra large von Willebrand factor multimers into a smaller, less active units. So this is responsible for the breakdown of this large multimer into a smaller inactive units of the von Willebrand factor. Now, what happens is if there is an auto antibody like IgG, they develop against this ADAMTS13, thereby inhibiting the enzymatic activity. So this leads to the accumulation of the ultra-large von Willebrand multimers, which promote widespread platelet adhesion and aggregation in the small vessels, resulting in the formation of the microthrombi. So this is the basic pathophysiological mechanism on the basis of which the classical pentad of the TTP is recognized. And this will always be provided to you in the question related to that particular topic. The first one is microangiopathic hemolytic anemia features like presence of the schistocytes on peripheral smear, elevated LDH, and low haptoglobin. Another one is the thrombocytopenic features like there will be petechiae, purpura, mucosal bleeding. Another important finding would be the neurological symptoms, although it could be mild to moderate, like confusion, headache, seizures, or focal deficits. Renal impairment, which is again mild to moderate, less severe than HUS, on the basis of which it is particularly differentiated from the triad of the hemolytic uremic syndrome, and fever. Now, fever could be present or could not be. It's not like that every time the patient would be presenting with the fever. So this is the classical pentad of the TTP, which you have to identify in any question. Now, another one is the DIC, the disseminated intravascular coagulation, which is very commonly provided in the options and is in itself is a question. Now, what is the pathophysiology? Because based on the pathophysiology, only we are going to have the clinical features. Like there is always a triggering event, like there is sepsis, there could be trauma, there could be malignancy. So always initiated with a triggering event. So it is resulting in the tissue factor release, leading to thrombin generation. And as a result of it, there will be wide active or widespread activation of the coagulation cascade. Now, this leads to microvascular occlusion and organ ischemia. Like there will be organ ischemia of kidneys, lungs, and brain. So, because of the formation of the fibrin-rich thrombi. So all these, it results in the consumptive coagulopathy that results in thrombocytopenia and deficiency of the clotting factors. So the consumption of the platelets and the clotting factors is another feature in the pathophysiology. It results in activation of the fibrinolysis. So plasmin activation lead to fibrin degradation, where there will be elevated D dimers, and it results in the bleeding tendency. So depletion of the platelet and the clotting factor along with fibrin degradation, it leads to spontaneous bleeding and ultimately the multi-organ dysfunction. It is due to ischemia from the microthrombi and the hemorrhage into the vital organs. So this process results in the consumption of the platelets as well as the coagulation factor, leading to paradoxical state of both thrombosis as well as that of the bleeding. So as you know that there is going to be a presentation like the bleeding from the skin, mucous membrane, the gastrointestinal tract in the form of melena, hematochezia. There could be intracranial bleed. There could be bleeding from the surgical sites. There could be pulmonary symptoms in the form of ARDS. There could be hypotension, shock, myocardial ischemia or infarction. There could be bowel ischemia, abdominal pain, paralytic ileus. So it is a very poor prognostic condition where there is consumption of both platelets and coagulation factor, resulting in the paradoxical state of both thrombosis and bleeding. Now, as far as this HUS is concerned, if a child is suffering from a bloody diarrhea because of sugar toxin producing E. coli, so there will be an endothelial injury to the due to this sugar toxin that results in the microthrombi formation. And this formation of the microthrombi results in the classical triad of hemolytic uremic syndrome, which is identified as the features of the microangiopathic hemolytic anemia, thrombocytopenic features, and acute renal failure, which is more severe in comparison to what we have witnessed in TTP. So there is a severe renal involvement which is more prominent than the neurological symptom, and this is how exactly we are going to differentiate it from TTP. And then coming on to the idiopathic thrombocytopenic purpura. You already know that it is a auto antibody mediated platelet destruction. The most commonly are the IgGs, and these IgG antibodies, they are directed against the platelet surface glycoproteins. And you already are aware of what these platelet surface glycoproteins are. It is the glycoprotein 2B3A, which is involved in the platelet aggregation, and the glycoprotein 1B9, which is involved in platelet adhesion to the vascular endothelium via von Willebrand factor. So all this results in the isolated thrombocytopenia due to autoimmune destruction of the platelets. Now presents with the petechiae, mucosal plating, and the bruisings only. So there is no anemia, there is no schistocytes, there is no feature of microangiopathic hemolytic anemia, normal coagulation parameters, and no systemic symptoms in case of thrombocytopenic purpura. So this is how you are going to differentiate each one of them. Now, as far as the another component of the question is concerned, because first thing that they will give you or they will provide you are the clinical features. The second thing are the laboratory findings on the basis of which you have to confirm your diagnosis. Like as far as platelet count is concerned, it is markedly decreased in case of thrombotic thrombocytopenic purpura. There is no doubt about this, but it is slightly decreased in all the other three conditions. As far as hemolytic markers are present, so it is consistently present in all like TTP, DIC, HUS, because there is marked hemolysis, but it is normal in case of thrombocytopenic purpura. The PTINR as well as activated partial thromboplastin time, both of them are prolonged in case of DIC Rest, it remains normal in all the other three conditions. As far as this fibrinogen levels are concerned, it is again decreased in case of DIC because it is the main pathophysiological mechanism for disseminated intravascular coagulation, while it is normal in case of TTP, HUS, and ITP. D-dimers, they are normal or slightly increased. Normal or slightly increased in case of HUS also. They are normal in case of ITP, but they are markedly elevated in case of DIC, and you can very easily relate it with the pathophysiological mechanisms. As far as renal function test in the form of serum creatinine is concerned, so they could be slightly variable in case of TTP as well as in case of DIC. But in case of HUS, there is a severely raised creatinine levels because of the acute renal injury. And bleeding tendency is also severe in disseminated intravascular coagulation. So, on this basis, whatever you have studied is now getting consolidated, and you can very easily reach the answer related to that particular question. Sometimes they used to ask about the management of the TTP also, and the management of the TTP include the steroids, the IV intravenous immunoglobulins, or splenectomy. And now you can very easily identify by looking at the question itself. Let's see what is being provided in the question. The 32-year-old woman presents to the emergency with a 3-day history of fatigue, confusion, and easy bruising. Now she reports petechial rash on her lower extremities, bleeding from the gums, and mild abdominal discomfort. So this is one of the feature which is related to thrombocytopenia presented to you. The second is she denies fever, recent infections, or diarrhea. On examination, her temperature is relatively normal. Blood pressure is slightly increased, heart rate is slightly increased, and she appears mildly confused but oriented to person in place. So, a neurological feature is also provided to over here. But fever is, the temperature is relatively normal. Now, there is no scleral icterus or hepatosplenomegaly. And neurological examination reveals mild disorientation but no focal deficit. So, at least from this question, you can say that there are two particular things that she is suffering from. One is the features of the thrombocytopenia, and the other one is the neurological features. Then the laboratory investigation. You can see the hemoglobin is low, but the platelet count is markedly decreased, right? The reticulocyte count is elevated, LDH is elevated, haptoglobin is undetectable. So there are the features of microangiopathic hemolytic anemia which are present. So that is the third finding which is present over here. As far as total bilirubin is concerned, it is found to be elevated. Peripheral smears, it shows numerous schistocytes, which is again a feature of MAHA. The coagulation profile is absolutely normal. Serum creatinine is mildly elevated. That means renal features are also there. And urine analysis, it shows proteinuria and hematuria. So if you combine all of them, like if you combine the features of renal disease, if you combine the features of MAHA, if you combine the neurological deficit, if you combine the features of the thrombocytopenia, so at least to some extent, excluding the fever, we are getting that all the 4 features out of 5 are present. And therefore, the most likely diagnosis for this particular question is the thrombocytopenic purpura. And you can very easily rule out the other options also, like why is it not HUS? Because of absence of acute kidney injury. Why is it not ITP? Because of the features which are MAHA, like schistocytes, LDH, they are present. Why is it not DIC? There is no such clinical feature which is presented in case of disseminated intravascular coagulation. Hope you have found the session helpful and might help you in marking the answers related to this topic. All the best for your future examinations. Thank you very much for listening. Join our Telegram group in order not to miss any update.